Good morning and good evening and namaste to
Wait,
all
ma'am.
of you.
Good
Is
to
it
go, ma'am. You are live now.
Okay, thank
good
you.
morning and good evening and namaste to all of you. We are here in this webinar, which is a very much important, and I bring the greetings from Indian Fertility Society, and I welcome you all, especially our international speaker. In this pandemic, we are absolutely closed and keeping the social distancing. But what will happen once we will open up? So this webinar will bring this answer probably. We do not know, but this is the trial that we can think over. That what will happen once we will open up, how we will tackle the problem. So I will forward to Dr. Bharti, the Vice President of Indian Fertility Society, to take the proceeding further and introduce the webinar.
Thank you. Thank you, Dr. Sudha. Welcome and greetings from Indian Fertility Society, Delhi. And this is the first webinar, and a dynamic person, Kunju Mohiddin, has been organized this all South Zone webinar. Sometimes life isn't all rainbows and sunshine. Sometimes it is maybe hard times like dark and gloomy. And it's important to use these difficult times as a life lessons, growing and shaping to blossom ourselves stronger and wiser. Every day, and we have to keep going, face these challenges. So with this challenge, today's webinar is on current challenges being faced by the reproductive medicine practice in the current scenario of COVID-19 pandemic and how to restart, because we know everybody has been closed down now. How do we restart fertility practices? That is, we know that is completely elective, no emergency. And right from the day of lockdown, say 24th of March, we have all stopped our fertility practices. So now we have reached to a stage that we must know now to live with this COVID-19 until we get an effective vaccine or maybe any medicine or drug which can give us the right answer back. And to discuss this and to guide forward, like how different countries, different places, this all things is going on, we have a very renowned international faculties and a national faculty to discuss and guide us forward. To introduce the senior faculty first is Dr. Stephen. Welcome, Dr. Stephen. Dr. Stephen is from Wright State University, Ohio, USA, and who is the President, Society of Reproductive Surgeons. Second senior faculty, international faculty, Dr. John Petroza. Welcome, Dr. John Petroza, from Massachusetts General Hospital, Howard University, where he is the Director, Division of Reproductive Endocrinology and Infertility. And third senior international faculty is Dr. Bala Bhagwat from University of Wisconsin, Madison, where he is a Director, Division of Reproductive Endocrinology and Infertility, and also a Chief Robotic Surgeon. And our own Dr. Sonia Malik, you all know that. She is a past president of Indian Fertility Society and a very dynamic academician. And with this, a very interesting panel, which is going to be moderated by our secretary, Indian Fertility Society Secretary, Dr. Neena Malhotra, a thorough academician. Hello, Dr. Neena. And Dr. Mohiddin, again Joint Secretary, Indian Fertility Society. So this is a very interesting and enthusiastic and academic person. Again, Kunju Mohiddin, very busy. The first time in his life must have been stopped like this. So the both of them are going to take over and conduct this whole panel, and I hope we all will enjoy. We'll know many things from different aspects, and how can we go ahead to restart the fertility practices. So hand over to Dr. Neena and Dr. Kunjamodi. Thank
Thank
you.
you, Bharti. Thank you, Bharti. Thank you very much. Without wasting time, let's go forward to hear our first speaker, Dr. Stephen Lindheim, who, as you already introduced, is the president of Society of Reproductive Surgeons. He is from the Wright State University, Dayton, Ohio. And we'll want Dr. Stephen Lindheim to speak on pre-procedure risk mitigation, focus on COVID, tests, symptoms checks, prioritization of cases. Over to you, Stephen.
Thank you very much. Good evening, good morning to where everybody is, and thank you for having me today. This is not without challenges. We have to really divide this into two categories, the patients, our priority, but also for staffing as well. So we have to think about, as we reintroduced our surgical procedures, our ART procedures, that if we can keep it simplified in that two ways, patients as well as our clinical staff. We have tried to come up with a simple way in which we can think about doing screening. We have, through ASRM, Society of Reproductive Surgeons, we have gone ahead and submitted our second or our first update for recommendations. These screening questions for both staff as well as patients would include a couple of things. One would be screening for symptoms. So again, we want to delineate screening versus testing. And we would recommend that anything like in the past 48 hours, the standardized way in which you evaluate somebody that may be sick would be including fever, cough, shortness of breath, perhaps a sore throat, diarrhea, fever, chills, and loss of smell. In addition to having symptoms, you want to think about screening for potential exposure. So if we think about in the past 14 days, have you had close contact with anybody who's had a known my apologies, my screen does not look like it's being shared. So I'm going to go ahead and do that. Hopefully you've been able to hear me. Okay, so as I had mentioned, screening for symptoms, now screening for exposure in the past 14 days. Have you had any close contact with anyone with known COVID infection? Are there any household contacts? Have you not socially distanced where you have been within 6 feet of someone who has a known COVID virus, and potentially direct infectious screens for COVID-19 patients? So this would be symptom screening that we would consider about would you let that patient initiate therapy, or even if you have that patient that is currently in therapy, you have to make a decision. Are you going to let her move forward with completion of that therapy, whether that's an egg retrieval or whether that's a surgical procedure in the office? And those are very good questions that we can consider further in this discussion today. With respect to the actual testing, lots and lots of controversy. We don't have adequate antibody screening right now, given the high false negative rates. Ideally, it would be great if we could do antigen testing on everyone. And I think that's where the standard is going to be going, is doing antigen screening prior to therapy, and then also when we get to the actual procedure, and then making the decision, are we going to be moving forward or not with those patients? So that's just a general broad overview, again, for patients as well as our staff in terms of screening and testing. Thank you. Is everybody able to hear me at all?
Yeah.
So I hope that addressed sort of some broad overview points to get us started.
Thank you, Steve, on this good and very, very, affirmative start where we do understand our priorities and we do understand how we're going to go back with our limitations on the testing. I think, Kunju, we can move ahead with the next speaker, and then we can have the questions come back at the end, or do you want to take questions right now?
Your mic, Kunj,
Your mic is you to unmute.
Is on mute.
Yeah, we'll have the questions at the end so that we can entertain maximum questions.
Okay.
And Dr. Steve, can you stop sharing the screen?
Absolutely.
So now we'll proceed with the second talk of the session that is very important. That is risk during surgery, COVID in reproductive tissue, cautery aerosol creation from tissue, aerosol creation from anesthesia. For this, we have an excellent speaker, Dr. John Pitosa from Massachusetts General Hospital, Howard University, US. And he's the Director, Division of Reproductive Endocrinology and Infertility. Also, he's the Vice President of Reproductive Surgeons Society. Over to you, sir, Dr. John Pitosa.
Thank you so much. And I appreciate the invitation to speak on this very important topic. First, I'd like to talk about prioritizing surgery. And this is going to be important because wherever you're located, if you're in an academic center, if you're in an ambulatory surgical care unit, it is important that prioritizing surgical procedures be discussed, because what will happen and what we're seeing here, at least in my hospital, in my region, is that surgeries are being prioritized so that they can start to consider what cases need to go first and what cases are considered secondary. And for us as reproductive surgeons, it is paramount because a lot of our patients are trying to get pregnant. A lot of our patients are in the process or were stopped with their treatments as they were getting ready for surgeries. And a lot of our patients who do have surgery need an extended period of time to recuperate. So it's very important that you prioritize the surgeries accordingly. And for us, and for the Society of Reproductive Surgeons, we have put together a joint document with several of the GYN surgical societies where we have listed these cases as tier 3 or urgent. And that's very important. So when you get to the point where you're starting to ramp up, it's very important that you have a representative who's discussing with your surgical team, your center surgical team, to make sure that these are prioritized accordingly. Now, one of the questions we often get is, what are some of the risks that I need to be aware of when I'm doing a surgery in the main OR? What are some of the risks that I have to consider for my egg retrieval procedure room? Because they're all surgeries, but to a different degree. And one of the questions that we've explored is whether or not the COVID virus is located in reproductive tissue.
John?
And as you can tell, there doesn't seem
John,
to be
if you can hear us, can you share your screen, please?
Yes, I will share my screen.
It should be at the bottom.
Yep, I'm just trying not to share my
move your cursor down to the bottom of the screen, it should pop up. It's probably, there you go.
There we go.
Thank you.
So when it comes to human tissues, we know that the virus is seen in the respiratory system, in the gastrointestinal tract. And we know that the virus needs this receptor called the ACE2 receptor in order for it to enter into the body. And so knowing that we haven't seen the virus in the reproductive system or no one's reported it yet, it makes sense to look to see whether or not the ACE2 receptor is found in the reproductive system, in the female reproductive system. And so far that hasn't been located. We do see the ACE2 receptor in other organ systems, the small intestine, the testes, the kidneys, the heart, the thyroid, and even some of the adipose tissue. So for reproductive surgeons, where we're typically working on fallopian tubes or ovarian cyst, or doing myomectomies, in my opinion, it's safe to go ahead and cut into these tissues, use cautery, use harmonic or ultrasonic scalpels. And as far as I know, to date, there hasn't been any isolation of the virus in seminal fluid or in follicular fluid. So that's all encouraging news. That being said, you are cutting into blood vessels, you are cutting into some fatty tissue, and I would caution anybody who does surgery to make sure that you minimize the amount of plume that you're creating, the amount of smoke that's being created. Sometimes that's hard to do, sometimes you can do it very easily. And I would say that a laparoscopic procedure is probably the ideal case to do if you can do it, because it's a contained environment. You're containing the smoke, you're evacuating it ideally through filters that are allowed, that can isolate the virus particles. And most systems, most laparoscopic systems should have a filter coming from the CO2 and should have a filter going out where you're aspirating and suctioning out the smoke. So that's very, very important. If you're doing an open case, it's important that you try to contain your smoke by using cauteries that have a smoke attachment, a smoke evacuator attachment to it, to try to pull the smoke away from the operating site. Now, one of the things that I always get concerned about, and this is important for egg retrievals, because I suspect most of your members are very worried about ramping up and how are they going to set up their egg retrieval suite. And one of the things I worry about is what happens when the anesthesiologist is manipulating the airway for your patient. Here in the United States, most centers have an anesthesiologist who administers the sedation, administers the pain medications, and many anesthesiologists do this in different ways. And one of the things that we are concerned about is aerosolization of viral particles. We know about COVID, we know about droplets, we know about staying 6 feet apart, but when you aerosolize a particle, that particle theoretically can go more than 6 feet. It can linger into the air, and that becomes a concern for you and your staff. And the aerosol generating procedures that we know that anesthesia does, especially in an egg retrieval room, is going to be intubation, insertion of a laryngeal mask, and suctioning the oropharynx. Nasal cannulas and O2 masks are not considered aerosol generating procedures. So if your anesthesiologist is manipulating the airway in a way that's going to generate aerosols, it's very, very important that your staff be prepared for that. Most procedure rooms, at least here in the United States, when we do egg retrievals, are positive pressure rooms, right? Your lab is pushing the air out of the lab, is pushing it out of the procedure room. So you have to factor that in as well. So if your anesthesiologist is generating aerosols, the air in a positive pressure room is going to circulate about 12 times, so that in about 12 to 15 minutes, the air should be cleared out of that room. If your procedure room doesn't have any circulation of air, it's a neutral pressure room, it's going to take about 48 minutes for that entire air volume to circulate through the room. So you have to think about that. You have to say, okay, is anesthesia generating aerosol? How long does it take for the air to circulate? Because that's going to be important for when you can bring in your next case for an egg retrieval. And then you have to think about putting protective equipment on your staff. And if you're generating an aerosol, you have to ask yourself, okay, is there, have I tested my patient? What is the prevalence of the virus in my particular region? And this is a topic of hot debate, because not everybody has access to all the different types of protective masks or protective gowns or protective gloves. And so you have to prepare yourself for that. So if you're creating an aerosol generating procedure, if you're in an area where there is a moderate to high amount of virus that's still infecting people in the community, and if you don't have the ability to test, I would encourage you to use maximum protection for your staff. You're obligated to do that. If you have the ability to test patients with a validated test, and if the prevalence level gets low in your community, you can probably get by with just regular surgical masks and gowns. But it's very, very important, as Dr. Lindheim said, that you protect your staff and you protect yourself and you protect your patients. And for me, the one area that most people have to be very conscientious about is what happens in the egg retrieval suite. I will unshare my screen. Give me 1 second, I apologize.
Have you completed the presentation?
I have. That is all I have for now. Let me share my screen. I apologize.
Could you tell us a bit about the PPE guidelines as well? That is the last line on your page at the moment.
So
I think
I'm going to be
Dr. Bhagat.
talking about PPE, so it'll be a good segue.
Okay, right.
So can I introduce Dr. So let's move to the third presentation, which is by Dr. Bala Bhagwat. I think most of us know him. He is at the University of Wisconsin-Madison, US. He's a director of the REI, and he speaks today and deliberates on PPE and ART, introduction of IUI ART back into practice. So over to you, Dr. Bala, for your presentation.
Okay. Maybe if I share, John will be unshared. So I'm going to see if I can share. You cannot. Okay. John, you need to unshare your screen, unfortunately.
Yeah, I'm trying to do that. I'm trying to.
There is a, on the top panel, there is a stop sharing button. You can just click on that.
Yeah, I think what's happened is my screen has minimized and it's not showing me that part to unshare.
Oh, maximize your screen again.
As a full screen.
The host can do it, no? The host can do it. Sanjeev?
Okay, thank you.
Yeah, sir, we are trying to do that.
While we're waiting, so thank you very much for inviting me. I am grateful to the Indian Fertility Society for the kind invitation, and good morning to people here in US, and good evening to all the viewers in India, and good afternoon if anybody outside of these two zones are tuning in as well. These are very uncertain times, and we are trying to struggle through and muddle through this whole process. It's not that we have had this experience before, even though we've had other similar epidemics, as the SARS and MERS. They were not on this global scale. We don't have the experience to draw upon and say, this is how it was tackled in the past, and we can proceed in the current times. So there are so many unknowns, and in these unknown times, okay, looks like you can start sharing now. It is very imperative that, desktop one. Let's see if it shares, allows.
You can see share screen button.
I'm sorry, give me a second. Yeah, well, it's I have allowed Zoom to share its thing. Okay, I am with you. Okay. Okay. Hopefully now you can see it. Let's see. Apparently my privacy setting had prevented it from sharing it. Okay, let's see.
Sanjeev, can you look into it?
Yes, sir. I am telling him like how he will be able to see the screen.
Let me see if I can try again. There you go.
Sir, at bottom of your screen, you will.
There you go.
Yeah.
Hopefully now you can see it.
It has come. Fine.
Yeah. Okay. So one of the things as we go into this pandemic that we ourselves recognized was how little we know about PPE ourselves as physicians, as a medical community. And as I spoke to my friends on the front lines, other specialty physicians, it was starkly apparent to me that these standards are very different. To give you an example, it's not just in India. I can tell you even here in the US, where everything is supposed to be very standardized. I work in a system, the university has 2 hospitals, and every year we get fit tested for the N95 mask, because our body habits can change. We can lose weight, we can gain weight, we may develop a beard if we are men, and all these things have a huge impact on how well it protects you. So we get tested, and we found out in this pandemic that the uh, company that is used, the product that's used to get these N95 masks are different. One hospital uses a different company, and the other hospital uses another one. And the two systems apparently are not exactly apples to apples. So just because you are using say, a medium mask in one doesn't mean that it fits you in the other, because you have to be fit tested individually for each product, which is mind boggling. So as I was talking about this with my friends in India, it became apparent to me that there's no such process there. There's no fit testing. One size fits all. There's no standardization whatsoever. And even the understanding of what different masks do and how they help us is rudimentary. So my hope is that since this is our first line of defense, in addition to testing the patients, which itself has a lot of constraints, but the first line of defense for us and for our patients is adequately protecting the patients and ourselves through PPE. I want to concentrate upon that a little bit more. Okay, can you still see my screen?
Yeah.
Okay, so gowns, masks, shields, and gloves. And these are really the minimum requirements for personal protective equipment. And in that regard, the masks are probably the most important. We wear it all the time. Gowns, in certain cases, the shields, again, now especially with COVID, the importance of that has been brought to the fore. And of course, gloving. With gloving and masking, they are very basic principles, but there are certain guidelines that are actually not followed. And I want to concentrate upon that a lot more in this presentation. I did a quick search of what's available in India. And one thing that I recognized is that you do not have any standardization. The masks that are sold there, they talk, excuse me, they talk about 3-ply, but there is no grading system involved there. So as I talk about it now, you have to try and convert that in the Indian context a little bit. The other thing is the respirators. Let me go back. So you can see here, it says this K95 protection mask. And I don't know what K95 means, to be honest with you, because as I will explain to you in a minute, the lettering system has a specific reasoning behind it. And I don't know what K stands for. And hopefully in the Indian context, it has meaning. And at the end of this presentation, those of you with the ability to do so can investigate further what it means. But let me tell you what the international standards are like. What are masks and what are respirators? Masks are coverings over the nose and mouth that have no airtight seal. They are classified by ASTM guidelines. It's American Society for Testing Materials, ASTM, and they're classified as levels 1, 2, and 3. And I'll explain that in a minute. Whereas the respirators have airtight seal. So therefore, only what you breathe cannot go out except through the mask itself, but not by the sides. And they are classified by National Institute for Occupational Safety and Health, or NIOSH. And if you get any N95 mask, it should actually, in addition to the manufacturer's seal, should classify NIOSH and then the number, denoted by letter and number. Everybody is familiar with N95. And within the respirator category, there is a special one that's PAPR, which is powered air purifying respirator, which is like a self-contained underwater breathing apparatus. Cuba, everybody knows about it. That is an underwater breathing apparatus, but it's modified. It's not underwater, it's SCBA, but here we call it PEPR. I'm not going to concentrate so much on it. Even in the resource-rich countries, they are very few and far in between. They are not that widely available and cannot be used widely in the Indian context as well. So what is ASTM levels? They are based on very standardized testing, okay? There are, as you can see here, there are multiple things that they concentrate upon. One is the pressure with which they force the synthetic blood through the mask to see when it starts leaking. With the level 1 mask, it should withstand at least 80 millimeters of mercury and not allow the synthetic blood to go through. And as the levels go up, you can see level 3 mask can withstand up to 160 millimeters of mercury pressure. And then in terms of differential pressures, bacterial, filtration efficiency, nothing is 100%. I want you to recognize that. Nothing is 100%, but the filtration efficiency goes up as well. And then how small a particle and with what efficiency that can be filtered out. So normal mask is helpful to protect yourself in situations such as short procedures. For example, the low barrier protection. If a dentist is using it just to examine, that is okay. But if the dentist is drilling in, then the potential for aerosolization is high. And with aerosolization, you want the maximum barrier protection, but not low barrier protection. The similar thing applies in the OR for us. If we are actually operating on the patient, even if it is only laparoscopic, the potential for splash and potential for blood being forced at higher pressure through the mask is there. And therefore, the imperative to use a level 3 mask as opposed to a level 1 is there. Unfortunately, in the Indian context, I could not find whether an ASTM level is even assigned to mass. Hopefully, those that are procured by hospitals and clinics have that level of testing performed before being sold. And again, that's for the Indian audience to investigate further and determine. So as I explained, if in our context, in the clinics, the level 1 mask is good enough for when you're sitting across the patient and talking to them. I'll come, towards the end of this presentation, I'll talk about how to start a clinic and what you should be doing and the ASRM guidelines that have just been released on that. You want to make sure that the droplets do not penetrate, at 6 feet distance minimum. So if you're going to be meeting a patient and having a consultation, you're going to place yourself about 6 feet from the patient, and the patient should be wearing a mask, you will be wearing a mask, and this is a minimum level mask that you would be using and your staff should be using, depending upon the procedure. Again, in what context they are interacting with the patient. And that context, I'll show you in a minute how that changes the level of protection you use. And as I explained, the level 3 mask is important when you're in the OR, the risk of splashes. Even if you're doing an egg retrieval, we have had cases where blood's seeping out. And if there's a potential for blood splash, you should hopefully be using a level 3 protection rather than a level 1. And in terms of the respirators, which are really the rage, I could see that shortages are there in India as well, and there is a lot of marketing going on for these masks. But what do they mean? Especially when I saw the K95, I was really confused. And hopefully there is a system involved as opposed to manufacturers just assigning numbers by themselves. So the letter really denotes the ability of the mask to resist oil penetration. N is not resistant to oil-based particulates. And there's a big concern here in that we know these viruses are coated by lipids. So they are essentially oil molecules. And an N mask is not resistant to oil-based particulates. Whereas, as opposed to that R mask, they are graded, again, the numbers are 95, 99, and 100. R is resistant to oil-based particulates, and P is oil-proof. Now, this completely eliminates any oil from getting in. And obviously, a P is better than N and better than R as well. And the numbering system, the 95, means 95% of particulate matter is filtered. So it's not 100%. And 99 stands for 99%, and 100 actually is 99.97%. Nothing is 100%, but 99.97% is still better than 95%, and 95 is better than a 0% for sure, no doubt. So as you can see in this grading system, a P100 is the highest rated mask that you can get. Sorry, not mask, respirator that you can get. We should stop using the word mask because they are respirators. And the N95 respirator is the least of these respirators that you can get. So it's a minimum standard in actuality. So what does this mean in terms of the virus itself? Just to highlight, they are generally used. When we are fit tested here in the US, we always talk about and worry about tuberculosis, honestly. It is for tuberculosis, and patients who suspected are known to have tuberculosis. When we interact with them is when we use the N95 mask respirators to a large extent. And tuberculosis is a 1 to 3 micron size bacterium. Now, varicella is 0.15 to 2 microns, and SARS-CoV-2 is 0.1 micron on average, anywhere from 0.05 micron to 0.15 microns, but on average is 0.1 micron size. So as you can see, the testing has been done for 0.3 microns. So when you are testing for 0.3 microns and say 95% of the particulates are filtered using a N95 respirator, and those particles are actually 0.3 microns or higher, does it really help? That is the biggest question. Does the N95 matter when the virus is even smaller than that? Actually, yes. The answer is, it is, these are standardized testings for its minimum standards, but these masks do provide some protection even for smaller particulates. Not as much, however, and as I explained a little bit earlier, even 95% is better than 0%. And if it can filter 60% or 70% of the smaller particles, you're still better off than being completely exposed and naked. So from that perspective, they are helpful, but it's very important that they are also used in an appropriate manner. And the other biggest concern is that nobody is fit tested in the Indian context, and the sizes are not being paid attention to. So I'm going to play a short video. This COVID crisis brought forth, even in the US context, the importance of the number of staff that are not even fit tested. And here in a rush, we went ahead and we were testing everybody. So it's a short video explaining what it means.
Had not been fit tested for an N95 respirator in the past, and those hoods are not as readily available as the masks themselves. So we have pivoted our efforts to refit test those people into an N95 respirator.
All right, everybody ready? The first thing they'll do is they'll put the hood on. We spray the Bitrix, which is what's called a sensitivity test. It's really low. They're going to taste it so that they kind of get familiar with what it's going to taste like if they do, but we don't want them to, right? Because that's how we know the mask fits. So they'll take it off, then they're going to don, meaning put their mask on correctly, put their hood on, and then we're going to run through a 7-minute test and make sure that during that 7 minutes, they cannot taste that Bitrix. Then we know you have a correct fitting mask and you're going to be protected at all times.
Every day I work with patients, but I don't use N95s hardly at all. So it's very important, and this disease is very concerning and very spreadable, and so very important.
Just throwing a mask on doesn't mean it's going to protect you from airborne hazards, right? So going through this gives you confidence, and then you know you have the correct PPE that you need to wear to do your job on taking care of patients.
we are fit testing?
So, again, in the discussion, probably we'll talk more about this, but and donning and doffing is another very important aspect of it. It doesn't help you if you have worn the mask appropriately, even fit tested appropriately, and then when you're taking off, you contaminate yourself, and all the protection goes to waste. So doffing is very, very important. Donning is important, but doffing is probably even more important. And even taking gloves off. I'm going to show you a short video again as explaining how to take the gloves off and make sure that you're not contaminating yourself. When there's obvious contamination, blood, for example, it's easy and people will be more careful. But in the case of COVID, we do not know. The virus is there and you cannot even see it. And if you're not practicing the same amount of caution and appropriate removal methods, then you are likely to not only contaminate yourself, but contaminate others as well. So that's very important. Now, I am just showing some powered air purifying respirators. There's, again, a little bit of confusion when I was talking to my friends, and I realized that the importance of facial hair. Yes, with a respirator, such as the N95, facial hair would interfere. As you can imagine, it will not give you an airtight seal. So people should either be completely shaved, or if they have a mustache, the mustache should be contained within the mask and not actually be in the area where the seal is applied onto the face. But on the other hand, a paper overcomes that. So in the past, if somebody had a beard, they would say, okay, you can't be fit tested with the N95, you need a paper. And so that's how they would be documented in our hospital system, that they use the paper. But now, many of my colleagues who sported lovely beards had to shave them off because we don't have enough papers to go around. So they've all been told to remove facial hair so they can be fit tested for the respirators and use respirators instead. So here's a doffing method for the glove. Again, it might be too rudimentary for you, but I just want to make sure that everybody pays attention to how they remove gloves. And even if the glove is completely clean appearing in the current climate, you could be potentially contaminated with the virus, and you should make sure that you take all the precautions necessary as you take it off.
You should always use disposable, single-use gloves to protect your hands from bloodborne pathogens and other potentially infectious materials. When taking off contaminated gloves, do it carefully. Don't snap them. This may cause blood to splatter. Without touching your bare skin, grasp either palm with the fingers of the opposite hand. Gently pull the glove away from your palm and toward the fingers. Remove the glove inside out. Hold on to the glove that was removed with the fingers of the opposite hand. Without touching the outside of a contaminated glove, carefully slide your ungloved index finger inside the wristband of the gloved hand. Gently pulling outwards and down toward the fingers, remove the glove inside out. Throw away both gloves in an appropriate container.
So the importance is glove to glove, skin to skin. This is a dictum when doffing gloves to remember: glove to glove, skin to skin. And the importance of using the index and the middle finger turned outward so that you don't automatically or inadvertently contaminate your exposed hand as you remove the glove is important. Because I see many of my own trainees, as they remove the glove, they'll just grab with their soiled glove, they'll grab the cuff of the glove to take the one off before they remove the other one. It's very important that you recognize, even if you have the gown on and therefore your other forearm is protected, you are now contaminating that as well. So you want to try and avoid contamination as much as possible as you remove the glove. So what does ASRM say? For those of you who may not have seen this guideline, and if you're members, I would advise you to go ahead and get this guideline. It literally goes through every single scenario, and I don't want to go through that in this present in the presentation. However, it literally, as you can see, from clinic entry all the way down to post PACU unit, what are the potential risks, what are the masks that you would use for the staff and the providers, and what you would use for the patient. And I don't know if it is seen on the right side. It's hidden a little bit by the panel of photographs here for me. But I'll summarize it very simply. For the patient, at the very minimum, they have to wear cloth mask. As we are slowly beginning to get back into regular business as usual here, what we have advised our patients is that they have to be wearing a mask before they enter the facility. So most of the residents now are using masks even when they go outside. In fact, that has been advised that anybody in the public spaces should be using a mask. It could be a cloth mask. It doesn't have to have the ASTM levels that I spoke about earlier. And the reason is any mask prevents droplets from spreading, and it keeps it within the mask, and therefore you avoid the potential for dissemination of virus particles. So patients wear a minimum mask, no regulations, no levels needed. On the other hand, the staff, ancillary staff such as the phlebotomists, nurses, as well as doctors and advanced practice providers such as nurse practitioners, should be wearing different types of protective equipment based on what is the risk. If it's just a droplet risk, for example, patients talking to the front office staff, there's droplet risk. The patients in the consultation room, droplet risk. As opposed to the patient is in a blood draw station getting blood drawn, there's the risk for splash and needle stick. As opposed to in the OR, when the anesthesiologist is potentially manipulating the airway of the patient, there's risk for aerosolization. So in these situations, based on the risk, you advise different levels of protection. For droplet, just mask and gloves. Why? Because if they are signing something, giving some paper, and the staff is getting that, they can obviously touch a droplet and transfer the virus to themselves, so wearing gloves. As opposed to in splash, where you not only use a MG, stands for medical grade mask. In addition to that, you use a face shield because you want to try and increase the protection in addition to the presence of the mask, plus gloves. And aerosolization, of course, you want to even more maximize the protection to yourself and use respirators, plus a face shield and glove. And if you go through the previous, this table, you would literally find that repeated again and again. So multiple societies, ESHRE has come up with guidelines, the Italian Society has come up with guidelines, and so has ASRM. And remarkably, all the guidelines are very, very similar in terms of how to get back into the realm of doing providing fertility services to our patients again. What are the risks? There has been much consternation about the risks for the patient if we get them pregnant in this crisis. David Schwartz and Amarin Dalawal, this paper is very interesting. They have summarized all the available evidence, not just for COVID, but really for many coronaviruses that we have faced over the last couple of decades, and show that the risk is really minimal. There have been some rare cases of vertical transmission, but the risk is really minimal. And with Zika scare in the recent times, we of course want to be cautious, but these particular class of viruses over the last many decades have not been shown to be vertically transmitted. And therefore, we can take some confidence in that. Certainly at this point in time, COVID could be different. It is possible, and we don't have any evidence for early pregnancies as of yet, but we can take comfort in what history tells us. The other is what are the risks for pregnant women? Of course, reports are slowly trickling in. This is the latest. It's still in pre-proof stage, but I was able to read it. And again, with 116 cases of pregnant patients with COVID, the risks for anything from preterm deliveries to abortions to infected babies or mothers themselves having serious complications seem to be minimal. So those are encouraging things. But despite that, there has been abundance of caution across the world. Infertility societies have advised fertility clinics to shut down and now slowly reopening. Despite the shutdown here, we have been allowing our fertility preservation patients to go through. For them, unfortunately, cancer is not going to wait. Many of them were starting chemotherapy. And so we have, in my own clinic, have taken patients through IVF cycles for egg retrieval and cryopreservation of either embryo or eggs themselves, as the case dictates. Even through the crisis, we ramped up very quickly and started doing telephone visits initially until our capability to do video conferencings increased. Although we have been doing WebEx and WebEx meetings in our particular institution, WebEx was considered to be not compliant with HIPAA. HIPAA is, protection of, I don't know how much of the US context is known in the Indian milieu, but HIPAA is a concept of patient's identification, as well as all history is very confidential, and multiple criteria are in place to make sure that confidentiality is maintained at all times. And interestingly, WebEx was deemed by our hospital system to be not good enough for safety and security. And so we have something else, a different product that we use that was quickly ramped up. And we started using, for the last 2 weeks, we use video-based consults. So of course, we still can't examine the patients, but video consults, I can tell you from a personal experience, are way better than just telephone consults with patients. The general guideline, again, by most societies, including ASRM, is you wait for 14 days after the peak in the community. And again, that's the important part, is within the community, the peaks are happening at different times. And even the prevalence is obviously very different. I was talking to one of the leaders just before the conference started, and I was astounded to find there are pockets in India where no cases of COVID has been found. So those do matter. And so knowing your local milieu and what the risks are is very important. And of course, you have to follow the local guidelines and rules within the state or the community you're living in. We have the same here in the US. Different states are having different rules in terms of how long the shutdown lasts and what businesses are allowed to operate, including clinics. So they are within that purview as well. And so we have to follow those guidelines. But generally speaking, 14 days after the peak daily incidence in the community is when you should think about starting your clinic back again. Why? Because of the non-incubation period, 14 days. So it is allowing for 14 days after the peak to reassure ourselves that we have passed the peak and we can go ahead and cautiously reopen our businesses. In terms of IVF itself, in our context, it may be constrained because anesthesia, as Dr. Petrosa mentioned earlier, most of the practices you do use anesthesiologists and administer propofol under their supervision, and that is a problem. So if you do not have anesthesia and if you use IV sedation techniques, then it may not be such a problem. But especially in big institutions like UW, anesthesia is stretched, and therefore their availability may constrain when we start IVF back on. I will in a minute talk about how we are phased reintroducing services in a phased manner. But in terms of minimum requirements, all patients as well as staff doctors are screened on entry every day into the clinic. Questionnaire that Dr. Lindheim showed earlier, as well as mandatory monitoring of temperature for the staff, as well as the patients. Patients automatically screened for temperature anyway, but for the staff, this is a new thing. We log the temperature. If it is less than 99 Fahrenheit, they're good to go for that day. Between 99 and 100 degrees Fahrenheit, they are screened later again in the same day. And if it changes, then obviously they have to be quarantined. And if it is greater than 100, it's a screen failure, and automatically they have to go home and quarantine themselves. And then we have to do contact tracing. Partners, we have told them cannot come in. Even for semen analysis, we are asking them to drop off, collect the semen at home and bring it in rather than using our own rooms. Again, trying to minimize the footprint, the number of people who walk into the clinic and could potentially infect others in the clinic as well as the patients. And finally, we have also written up educational material for the patients, advising them about these unknown risks, the precautions we are taking, why partners are not being allowed, because understanding will help them follow these guidelines without getting frustrated by them. In terms of phase assumption, again, diagnostics is where we are starting now. We are allowing semen analyses, blood works. HSG is a problem. If you have your own C-arm in the clinic, then it's okay. But if you're now dependent on radiology, again, they may not allow you to get your patients in there. Saline sonograms, as well as office hysteroscopy, we are reintroducing now, again, because you can, in a normal clinic, we would have had all of these going on all at once, any given time. Patients coming in for monitoring visits, patients coming in to have IUIs done, patients having monitoring for not only IVF, but coming in for egg retrievals and frozen embryo transfers. But by introducing only the diagnostics to start with, you can space their visits and therefore the number of people in the clinic at any one time. The other thing that we have introduced is patients not waiting in the waiting area in the clinic itself, but waiting outside in the parking lot. We call them when they are ready to come in. And so they check in by phone. They call and say, I'm waiting in the parking lot. And then when we are ready, we call them and say, okay, can you come in now, please, to register and then move into. So they don't actually wait in the waiting area. And even in the waiting area, recognizing that it won't always be possible to directly take them to their rooms or to the phlebotomy station, the chairs have been positioned so that they are at least 6 feet apart. So many of the chairs have been removed from the waiting room. Before, of course, they were not really crowded, but they were closer apart. Closer to each other. And now we have moved them apart and fewer seats available. So these are all the things that you have to think about as you reintroduce your practice to the patients. Our next phase, we haven't started this yet, but we are ramping up, is monitoring visits as well as IUI. The hope is as we start that, we can move on to frozen embryo transfers, and final introduction is IVF. With respect to IVF, again, because we have the capability, We are on the day of HCG injection, the patients would have a nasopharyngeal swab testing, or on the day after if for some reason they couldn't get it. But every single patient coming in for egg retrieval would be tested, and if they are positive for SARS-CoV-2, the case will be canceled, and patients are being advised ahead of time. The only exception is patients who are high risk for severe OHSS, where you do not want them now to end up in the hospital and causing more potential for infection. We have decided that if there's severe OHSS, then we will allow those retrievals to go on. But again, there is consultation with anesthesia, there's consternation in our setting. Should we do that in the hospital and not within the IVF clinic setting? Because our IVF clinic is standalone, even though we are part of the institution. So with that, I would end my presentation and ask the panel to, if you have any questions, we'll be happy to take questions.
Yeah, we have one more speaker. After that, we'll have the discussion. You can start sharing your screen, Dr. Bhagavat.
Yeah, go ahead.
Yeah.
Would it be possible? Would it be possible?
Yeah.
Would it be possible if Dr. Petroza and I just quickly put up one or two other things from the slide presentation? Dr. Bhagavat did a fabulous job. And if you could just give me the floor for about 2 to 3 minutes, I wanted to just, as the next speaker comes up, put in some ethical elements that we most recently in the last 48 to 72 hours have been dealing with or are going to be dealing with. So if I could just quickly put this up, and Dr. Petroza, if you could also interject. Are you on unmute as well?
Yeah, please.
I am.
Thank you so much. And I'm going to go very, very quickly through this here. I did want to just put up in screen format, and I do apologize. I didn't put Dr. Petroza's name here as well, but I want to give my board members, including Dr. Bhagavat and Dr. Petroza, a shout out, as we put an enormous amount of effort regarding our views in starting surgical procedures with ASRM, and our second updates will be coming out hopefully within the week. As I mentioned very, very briefly, the screening elements are very, very important. And as Dr. Bhagavat had said, deciding how we're bringing patients into the office, how we're doing distancing, letting one at a time. Those are all very, very important things that every clinic needs to decide. And I'll pop up the appendix that we are posting in our updates here in just a second. These are critical elements. If Dr. Bhagavat or if Dr. Petroza would like to comment on when I get done about really identifying each of these different time periods with regards to assuring that we don't have issues and that we can minimize potential exposure to patients as well as to staff. And this is the appendix of screening that I'd be happy to share, that this will be coming out. I think it's fairly standard, but will be coming out in our second update. And again, screening for exposure. I think some really, really important issues that have arisen are, when do you do testing for these patients? And really, we recognize that the antigen screening is critical and is paramount as opposed to the antibodies, particularly related to ART, IVF, where should we do it before we start stimulation? Should we do it as we get to trigger? These are very, very important questions. We are posturing the Society of Reproductive Surgeons are coming out with a joint statement of reintroduction of hospital and office-based procedures with SGS, AAGL, SGO, and AGUS. With regards to tiering these particular, you can't see this very, very well, but we're looking at tier 1, tier 2, tier 3, tier 4 in deciding what is critical in terms of procedures and what can be delayed extended periods of time. We'll be open to discussing this in this forum, or these statement will be coming out shortly. The last slide that I have here is, this is something that's very, very serious, as we all recognize. This is a New York Times article that just came out on Friday, where we have to be very, very serious. And while we're very, very caring for our patients, we have to take it very, very seriously and not just say that we're doing these things, because there are staff that are saying that we're really, really not taking their interests at heart. And I would open this up for dialogue or discussion, because, you know, do we not open up? We need to keep our economy going. Infertility is considered a disease. These are all very, very important elements. And as we're pushing forward with the economic part of it, we cannot forget the medical aspects of this as well. So with that, I will end it. Dr. Petroza, if you're there, do you have any commentary before we pass this back to them?
Yeah, just a couple thoughts. And first is, those are all good points. And as we've been stressing, you know, it is paramount that you set up policies that protect your staff and protect your patients. And some of the things that Dr. Bhagavat said, I just want to sort of stress. So for testing, at least in our institution, as a clinic, I don't have the opportunity to do testing in my clinic. My institution and a lot of regions have set up testing areas because they want to sort of control the types and the amount of testing that's happening. So if a patient is going to come in, and all of my patients prior to an egg retrieval are going to get tested, they have to be tested in a very specific spot. It's not in my clinic. It's in a hospital designed clinic where patients can come in and get appropriately tested. So you have to make sure, based on your region, whether or not you're going to have availability for those tests, what those tests are, and where they're going to be administered. And keep in mind that the validity of the test is often based on the prevalence of the disease in your area. A lot of these rapid tests, these nucleic acid tests, have a certain amount of false negativity based on the prevalence in your community. And you want to have a test that obviously has a very, very low false negative rate. The other thing is in your policy, have it clearly delineated and talk to your patients that if they become symptomatic or if they test positive at any point outside your center, they let you know, because you have to have a plan in place on how you're going to manage those patients that do become symptomatic or become high risk. Are you going to cancel them? There are some centers in this country that are saying, if they become positive or high risk, I will manage them as if they're COVID positive, and I will still do their retrieval, but in a very strict, isolated manner. So that has to be important. One of the concerns we're having here in Massachusetts, because we are a hotspot, is that screening patients may not be enough. Screening patients just based on symptoms. We're finding that patients aren't being truthful. They want to come in, they want to see their doctor, they want testing done. And so when we say, do you have a cough? Do you have a runny nose? Do you have any loss of smell? We're finding patients saying no on that symptom check. And then they go see their primary care. And then we're like, oh my gosh, they're seeing their primary care because they had a cough, but they told the person at the front door that they had no symptoms. And I do worry, I love my patients, but I do worry my patients have now been going on 6 weeks without having any treatments, that they may not be as truthful as we want them to be. They want to come in and they want to get their cycle. So that's why I think testing is going to be critical when we offer it. The other thing is when it comes to your PPE, your mask, your gowns and gloves, it is important that you have at least a 30-day supply of this equipment, because you don't know with resurges in the virus, because we're expecting that. Once we start to become a little bit more lenient and letting people out into the community and not being at home, we're expecting to see some surges in numbers, and we don't know what that's going to mean to the amount of PPE that's available. So it's important that if you're ramping up, you have about 30 days worth of PPE available in your clinic. And then the final thing I want to say is here in the United States, one of the concerns is what Steve alluded to, is that if we're not protecting our staff, at least here in the United States, the staff can claim that you haven't protected them appropriately as an employer. That's not an FDA thing. That's not a CDC thing. That's an occupational health thing. And even though in this COVID crisis, we've been told that the legalities of this COVID pandemic are going to be a little bit less. People can't sue you if you treat them because they're sick, or staff can't necessarily sue you because you didn't take care of them as their boss. Those are things you have to be very cognizant of. And I don't know what it is in India, what the rules and regulations are, but it's possible that if you don't provide your staff the appropriate equipment based on the risk of the procedure that you're doing, you may be liable for that. And so I want you to be very, very thoughtful about that. The last thing, this is the last thing, is I talked to you about aerosolization, and I'm going to show you a video on what I mean by aerosolization, just with a simple sneeze, and why this is important if you're not testing your patient. Let's say you don't test your patient, and the patient is having an aerosol generating procedure by your anesthesiologist, and you don't know what that means. I'm going to share a video of what one of the researchers here at MIT, there are researchers who focus on aerosolization. The whole concept of 6 feet is based on old literature from the 1930s, based on tuberculosis. But now that data is being refuted a little bit, that when you sneeze or cough, it actually may go a little bit further. Now I'm going to show you this, and despite looking at this video, the good thing is that here in the United States and in India, even with simple masks and keeping people at home and mitigating exposure, it's worked, right? So I don't want this to scare you. What we're doing is working. But when it comes to working in a unit with your staff where things can be aerosolized, I want to show you this video to give you an idea of what this means. Now I'm going to share my screen. Let's see here. And I don't know, can you see this? Are you able to see that?
Yeah.
So this is a researcher at MIT who's showing that this is more than just large particles. When someone coughs or sneezes, you're creating actually a cloud of particles. And it's these particles that we worry about when you're sitting less than 6 feet away from your patient when you're doing an egg retrieval, right? So some of the simple things that you can do, some of the simple things that they did in China is put a barrier between the patient and you. Just like you do in the main OR, you lift up the drapings so that the patient doesn't see you. You can do the same thing during an egg retrieval. In China, what they did is they put a mask on the patient. You can put a mask over a patient who has a nasal cannula. You can put an O2 mask over a patient that has a surgical mask so that when they wake up, a lot of our patients tend to cough and sneeze. You can actually minimize the risk of that aerosolization a little bit, especially if you don't have access to a lot of the appropriate PPEs, which I hope that you do. All right. So if the host can unshare that for me, that would be great. Oh. And that is all I have for now.
Ron, thank you. And we're going to turn it back over to you. We do apologize for taking up the time here, but thank you.
Thank you.
That was great. Both of you guys.
You can unshare his screen.
Oh, there it is. I got it. Okay, got it.
Yeah, that's done. Now we have the last and final talk of the webinar. And for that, we have none other than Dr. Sonia Malik. And she is the past president of Indian Fertility Society and is an eminent teacher. And also, she will be speaking on current scenario in India with regard to this infertility treatment and COVID-19 pandemic. And she is heading many institutions of standalone IVF centers, and she'll be the right person to speak about. Over to you, ma'am, Dr. Sonia.
Thank you very much. Once again, a very good evening to all of you. Sorry for that. I'm sorry. A very good evening to all of you, and I would like to thank Dr. Sudha and Dr. Nina, Dr. Kunjumuddin for giving me this opportunity to present what we all have been thinking at the Indian Fertility Society. And basically this, whatever presentation I have made today actually talks about our feelings and our voice as to how we want to address and what are the challenges that we probably are facing during this COVID crisis. So taking you through the fertility practices and challenges during the COVID-19, our scenario, the Indian scenario, let me just start by giving you a little bit of, I would say history now, although it is only two months history, but nevertheless, if we look at our challenges, then India is a land of great diversity. We all know that it's a continent, as people say, and it has different cultural thoughts and religious beliefs. There is a lack of education, there is lack of discipline, and there is a lot of political divide in the country. Of course, this is also the problem of abject poverty along, and then we have the upper crust millionaires. So there is a huge range of people. There's a lot of diversity in what we have to deal with, and therefore our problems. Now, with the corona pandemic, we had a major issue of controlling this pandemic of this magnitude. We have tuberculosis for a long time, and we all know that there are deaths happening because of tuberculosis in the country. But the magnitude of this pandemic was huge, and it has challenged our population of 3.7 million. Our healthcare facilities are lacking. There is shortage of hospital beds, as we found in other countries as well, and the equipment, the protective gear that we've been talking about, and most of all, the staff and there was also a lack of the trained personnel for this kind of a pandemic. Therefore, the country decided, the ministers or the people at the helm of affairs decided to lock down the country very early during this pandemic in order to flatten the curve and in order to buy some time. So this was done to a large extent. It has made some of the states disease-free, as we have seen in the state of Kerala, where it was first detected, and now today Kerala seems to be disease-free. So basically, we all know, and I don't need to talk to you about this very much, but we all know that it has actually flattened our curve to a large extent. And as you all are saying, as you all also pointed out, that we do not know yet what is going to happen once these lockdowns stop. But nevertheless, we are expecting that maybe, yes, we are able to fight this a little better than what we have done in the past. So, however, the nation the reports across the world keep telling us that we are underreporting because we are not testing enough. That may be true, but whatever it is, we don't find so much of serious disease and deaths taking place despite this critique, and therefore we tend to believe the authenticity of our reports. It also may be possible that because of the lockdowns, we don't have so much of serious disease, but nevertheless, whatever it is, this has actually encouraged us to now evaluate our problem again and try and see how best we can manage it in the current scenario. So, coming back to the challenges that are specific to our specialty, we go back to March 2020. Why did we close down our services completely? Of course, the nation wanted it so because we needed to divert the healthcare energies to where they were needed most. And since ART is an elective, all the procedures are elective, we did close down our services. And also we were not sure of the outcome because we did not know about the effect of the virus on the gametes. And we did not know how to keep our patient as well as our healthcare providers safe. So with that, we decided to close down our services completely. The ART centers were shut completely. And so then we were buying time. But then what has happened now in May 2020, the economic loss and the resultant unemployment is staring at our faces. We are also concerned about the availability of disposables and consumables, which are limited. And we know that the country is in lockdown. We are not importing much. And the least of all would be these disposables and consumables which are going to be imported because they are not going to affect a populous country like India. So therefore, with our limited stock, with the APIs which are coming from China, which again are under suspect, with all this happening, there is bound to be a lot of economic loss and unemployment generating in our centers, leading to maybe even shutdown of certain centers. So therefore, we are now looking at what we should be doing in order to start. Should we reopen? And if so, when and how? How should we do it? And when would be the best time for India to start doing this? So let us again go back to the challenges that we were talking about. We are not sure of the outcome. We were not sure of the effect of the virus on the gametes in March. But now we are still not very sure. But as Doctor mentioned just now, there are no ACE2 receptors found on the gametes or even in the uterus, which does indicate that, okay, we are at least safe when we are handling the gametes, and when we are putting back the embryos into the uterus. So therefore, they are assuring. And also these early reports regarding pregnancy also, which is happening during this pandemic, also indicate that the seriousness is not so much as it is to the reproductive system as it is to the other systems of the body, say the respiratory system. Therefore, it is assuring. Then again, the safety of the patient and ART workers, it still is a question because the prevailing tests are not 100% accurate, as we have just now discussed. And a large number of patients may be asymptomatic and may not be telling us, as Dr. Petrusa has just pointed out, that many of the patients may not actually reveal that they have a problem, and we may be taken unawares. Also, there is the non-availability of the PPE, which may become a question for our safety as well as for the safety of the ART workers. So therefore, keeping that in mind, we are a little wary of whether we should be starting or not. However, we have reorganized ourselves to a large extent, and therefore we are still considering that we may be able to start our practice again. Now, looking at the patient's perspective, how are they looking at this problem? We find that there are two kinds of patients. One patient who is very keen to restart because she's free now. She was she was overworked. She's a working girl. She doesn't get free time. From the office, no chutti, no leave. Hence, she's absolutely wanting to start it again and again. And we receive these calls from our patients every now and then saying, when are we starting? When are we going? This is going to last forever. Do something about it. And then there are patients who are losing time also because of their own problems, their own disease, and they are actually anxious because this is going to affect their future. She's actually not sure whether she'll ever have a baby in life. So this is one kind of patient. And the other one is a patient who wants to be absolutely sure of the safety of herself and her baby, and she's scared to come to the hospital or the clinic because she doesn't know whether she is going to come back safe or not, whether she's going to catch the infection once she visits the clinic. So these are the two kinds of patients that we have, and their challenges are different. So therefore, we gear ourselves to change our practice. And as we all have already heard from Doctor, we have also increased our teleconsults. We are consulting most of the patients on the phone, or we are doing video consults. The social distancing is going to be a norm, and therefore the social distancing norms are going to be very, very rigid and prevalent all along. Self-protection regimes to be in place. COVID testing should also be a norm, much like HIV, and patients could or should prefer to the standalone clinics where the problem of infection seemingly is less. Patients may not want to go to crowded hospitals where they are not sure whether they are going to come back infected or not. So this is the change that we might see in the practice. And of course, it's going to impact the ART majorly because the number of cycles is going to be reduced, restricted to only the local patients around you, because traveling may again be a little restrictive in the coming months, maybe for a year. And of course, patients are also going to review the funds that they have, because this is not priority. This may not be the priority for many patients, and they are definitely going to look at whether they can afford an IVF or not. Third-party reproduction may majorly get affected due to the increased chance of transmission, and we are not sure of our donors and surrogates. Therefore, we will have to take that part as a pinch of salt, as also the decrease in the international patients flying into the country, because they will be wary of coming to India, as we will be wary of treating them. Of course, the economic loss, as we can see, it is going to be humongous. We will have to downsize our practices. We may have to learn to multitask now, doing the task of 2 or 3 people that was being generously given to so many of our colleagues. And of course, minimizing the wastage that we have, downsize everything in the clinic so that we don't overspend at all. We cannot be magnanimous about anything. And then, of course, India has already, and especially our specialty, has already always been struggling to get funding for research. This is going to further decrease as I can see it, because funding agencies are also going to look at priority areas, and this may not be a priority area for India. So what is the way forward? There is an urgent need to bring in the ART law now in order to ensure quality in work. The guidelines for reopening must be issued by national fertility societies. We have actually issued one guidance about 15-20 days ago, and we are surely going to start another one. We have already a task force in place, as we all know. Dr. Sudha is heading that, and Dr. Neena is there with her. So with the task force, I'm sure the Indian Fertility Society is going to pave the way forward to bringing out the national guidelines. And of course, ICMR must also take a proactive step in that, because basically explicit SOPs are required both for clinical and lab work. This can be supplemented further by the state-run chapters, because as we can see, the practice in Kerala may be different from Kashmir. So therefore, each state has their own local problems and local way of looking at this pandemic. And they have actually curtailed the pandemic in different manners. It was different in Rajasthan, it is different in Delhi. So therefore, the SOPs that have to be made have to be general at the national level, but the state-run chapters will have to also participate and incorporate the differences in practices and local conditions for each region. Therefore, they have to be combined together. The clinics need to be monitored by regulatory bodies, which may be the fertility societies themselves or ICMR, but definitely monitoring is required in order to make sure that we do not end up with more infection this way. So working could be started as in a graded manner, as we have all been told earlier also from our American friends. We have to grade them, and work can actually start in what are called the green zones in India, where the infection seems to have finished, as doctor was pointing out, 14 days after the last one. Similarly, followed by the orange zones, and finally in the red zones. So it has to be graded. We cannot start opening ART in the entire country all at once. It has to be graded. Strict triaging would be required even before the appointments are given, and patients who have had the disease or are in quarantine recently would have to defer treatment. Inclusion and exclusion criteria for the treatment will have to be very stringent and laid down well, so that we don't get any surprises when we are starting with IVF cycles. So that is how we need to start looking at starting ART in India, and procedures where anesthesia is not required may be started first, gradually moving on to the others. As we have heard again from our friends, that anesthesia and the aerosol spray is actually the most frightening things in this particular pandemic or this particular disease. Therefore, we have to be very careful where anesthesia is required, and that is definitely one of the problems which we will have in our oocyte retrievals. And however, having said that, but being careful, we could be able to do that, because now with the endoscopy people also thinking of starting some procedures, we can also do it. However, the centers which are based in hospitals may have to make sure that the hospital has not been a COVID hospital when ART services are started, because that is not only going to cause more difficulty in making the whole area completely free, but it is also going to frighten the patients a little, because they would feel scared that they may get infected once they go there. Hence, that area may definitely be cordoned off and made into a green zone within the hospital itself before we can even think of starting an ART, before we can start the ART services within that hospital. So with these few thoughts, I think we can think of restarting the whole thing in our country as well, where we are now seeing that even though we are in lockdown, even though we have been asked to stay at home at all times, there are certain, as you can see in this chart over here on the side, that there are certain services which have been allowed, and the green zones are the ones which have been cleared of many things. So therefore, with that, we can take a chance and we can absolutely think of starting the ART services also, considering that the patients are getting a little restless, and of course there is an economic background to it, but then safety always comes first. So therefore, to conclude, I would say that COVID-19 is here to stay with us for some time. So we have to know how to look at it. It's a new disease which no one as yet has sure, and the information is not yet complete. We do not know the long-term effects of the disease. We do not know how long it is. Chikungunya has been there with a lot of pain in the joints for 1.5 years even. So we do not know what are the effects of this disease on the respiratory system of the people who have been affected by it, on the other systems of the body as well. The strategies to control and even eradicate are being developed each day, and humans have to learn to live with it by modulating our lives. So work we have to, but with extra care and precautions. And that is all, that is the bottom line. And that is the mantra for COVID-19 today. Live, but with care and caution. With that, I thank you all very much. Stay safe, stay at home.
Yeah, thank you, ma'am, for that wonderful.
No, nothing here. This is organizations only.
Thank you.
We'll proceed with the discussions. Dr. Nina, over to Nina for taking up. We have a lot of questions pouring in.
Yeah, thank you very much. I think I would really thank all the 4 speakers who've done a wonderful job from across the globe, especially giving us a perspective from US, how they are planning to move. And of course, Dr. Sonia, who's given the true wisdom and how we should and how we would look guiding us the way forward. So I think a lot of questions which I got from the viewers who have logged in the audience, I think have been taken care because they came very early, because the questions are basically on when should we start. And I think Dr. Sonia has really given the answer to that. We have to actually not just wait and watch, but if you're in the green zone, I think that answer has been really 10. I think if I would ask Dr. Sonia, because this question is when should we start? Can we start stimulating patients right now? Would you like to really throw light, ma'am, or would you sort of say, yes, we have to wait for a green signal from somebody? Or do you think where cities or centers are standalone, are in green zones, can they start doing, because they're asking, can we go ahead and do an OPU and start stimulating our patients?
I think, Nina, the need of the hour is to have a guideline from the society, which should be able to guide them over very small points. As you can see, Dr. Bhagavat has told us so much about the mask, the N95. We were not aware of such details about the respirator. So therefore, if we are able to generate a very detailed guidance for all the centers, then there is no harm in starting, because if the area is disease free and that area is in the green zone with the required precautions, which in any case, like I'm saying, we'll have to take in the next couple of years. We'll have to continue to doing it. So with that, I think we can allow units to start functioning. But having said that, a guidance is very important, because then otherwise what will happen is everybody is going to make mistakes, and maybe then we'll be in a bigger soup, because then ART units will be closed down because of the mistake of maybe 1 or 2 people. The entire services is going to be affected. So therefore, we have to take a very proactive role and start issuing guidelines.
Thank you very much. There are also concerns that, like the SRM and the ASHRAE, they said you'd freeze all. Now, freezing itself is putting the virus as 196, going down. So what would happen even if we contain the pandemic and we move forward, and when we thaw these later, do you think we could create a situation what we are going to face maybe 3-4 years when we thaw? So are we ready to take that challenge?
That is something that the ASRM is going to answer. They're all here. So I think they should be able to answer that question for us, because the guidance has come from ASRM.
Well, can I just take this answer, because after hearing a few of these webinars, which have, as I said, epidemic of webinars, and I was hearing some brilliant, meetings there. They said the only solution to this problem is dilution. So if you have, and you're thawing, the more you dilute in the media, and the thaw media is what you cannot make it absolutely free. And considering that we found that the embryos, even if they are not really affected, there are no receptors. So there were questions that liquid nitrogen would be, again, putting the virus to sleep, putting it to dormant. But if you are thawing these embryos, I think you have to dilute and wash your embryos at thawing, not one, maybe perhaps 10 times. So the overusage of the media is what is the answer that I could hear from these webinars.
I wouldn't know what the doctors here would say, but my own contention is that what you are saying was maybe told 3-4 days before. But since yesterday, all the webinars that I've heard are saying that there are no ACE2 receptors anywhere on the gametes and the uterus. So having said that, even if you freeze that, unless and until the media is infected, which means that your staff is infected. So here comes again the stringent control of safety of the staff and the workers in the lab. If we are careful about that, then yes, there is no question of having the infection in the cryopreserved embryos as well. But again, if we are not careful, it could happen. Bharti may have a different opinion and Kunju may be wanting to say something different if you want. Yeah, please. Yes, Dr. Petroza is one. They wanted, yes.
Yeah, I think keep in mind that the presence of virus, especially in some of these fluids, does not equal infectivity, right? And so as I talked to you about aerosol generation, one of the things with aerosol generation, for example, is that the virus is often fragmented in these aerosols, and we don't know the true infectivity of viruses in aerosols. And same things with anything that we would see in follicular fluid. So theoretically, there is virus in feces. It's been identified in feces, right? And so we're gynecologists, we're reproductive endocrinologists. Our procedures are done down in the genital area. It's not inconceivable that we could pick up virus in the vagina, maybe from fecal entry, and that could somehow get into our follicular fluid. But what is the infectivity of that? And that's what we don't know. And I suspect that you need a lot of exposure with the virus in order for infection to occur. And so I think as long as you're cautious, and as all these webinars you refer to, Nina, suggest, you're going to follow universal precautions in your lab. You're going to wash with the media as much as possible. I think that's the best that you can do.
Well, thank you, Dr. Petroza. There's another question, I think, which the surgeons would take it, because now we have understood that we're taking people.
Dr. Stephen would like to.
Sure.
I would just really emphasize, you're making a very important point here. There's such a concern that I would play devil's advocate. Well, then why do it? Okay, that's the first point. And the second point is that if we're going to do it, then prioritize. Because if we're making, and I'm not minimizing it, but if we're making such a big deal, then why do it? And that's my point. And informed consent is critical to what we do. If we're that concerned, we need to make sure that the patients are aware of that and are adequately consented for us to move forward with these procedures. Thank you.
Thank you, Steve. Well, again, this is one question just come, and I think it'll be a concern for all of us. While we do understand after hearing you all that when you're doing an elective surgery, we are definitely testing our patient for the COVID-19 through the RT-PCR. What will be our stand if we are doing an emergency surgery, say an ectopic, and we really don't know? So how do we treat? Do we wait until she gets the COVID status cleared, or we take her otherwise as a suspect?
I think you take maximum precautions. I think what's happening right now, for example, in Massachusetts, because we're a hotspot, any woman who has a C-section, any urgent surgery, any surgery that's happening now in Massachusetts, everybody is wearing maximum protection, even in those patients who test negative, because right now we have high prevalence. I think once again, it goes into the prevalence in your area. And so if you have a high prevalence in your area, you're going to use maximum protection. If you have a low prevalence, maybe you can make a decision as to whether or not you want to minimize things. But I would be very cautious. And I think for me, in order to protect my staff, I would try to maximize protection for them.
Yeah.
I don't know, Bala?
Nina, I can take that question as well in the medicine context. The broad view is that it's not only the prevalence, as John has pointed out again and again, also your testing capability. If you don't have enough tests, then you're now going to prioritize your resources. Also PPE. So what we have done here is our tests are 2 to 4 hours now, maximum 4 hours, but turnaround time on average in 2 hours, we know the results. So if you have the time, you wait for the results to come back before you take the patient to the OR. This is for C-section or in this case, an ectopic. But if you don't have time, if 2 hours is a luxury, then you assume that the patient is infected and the patient is, the whole staff, the whole OR, everything is geared up as though the patient is COVID positive. So if you don't know, you assume the patient is positive, even if they are asymptomatic.
You're talking about the testing. So could you, anybody of you, John, Bhargav, or maybe Stephen, what is the significance, like for cutoffs or the sensitivity of the COVID testing? How it is been, because it's not been sure, it is 70%, and then it is becoming very difficult, which patient to put where and how can we go ahead. And my second question was, India is a very hot country here, and we had a guideline in our own center now to test, the screen them for temperature. Now the patients, when are coming from outside, they have been so, it is humid, they are sweating, they have been very heat outside. Once they come, how can we assure that the temperature, if it is higher, that the patient has the COVID or the symptoms, and are we, how we are going to go ahead with that? That is the biggest question, because we are in our center going on the meetings now, how to start, and we have been preparing for ourselves. There are seminars going, everything, but in that this question comes, what to do now with these patients? Like anybody of you.
So the first one regarding testing, there's so many variables. It's amazing. There are 5 different tests that are approved, different companies. CDC is still the best. That's within the US context. And then we have private companies offering tests. And of course, they have individual sensitivities and specificities that are variable. And on top of that, one thing that became very clear, AAGL had a webinar, and the pathologist from Cleveland Clinic was on it. And he has done some studies using all 5 tests. And what is amazing is the transport medium. When you take the swab and you send the material, the viral transport medium, the type of viral transport medium you use seems to make a huge difference. So the sensitivity of the test as well as the specificity of the test changes based on the transport medium. And when they got back to the company and said, hey, what is it? And they said, well, you didn't use the transport medium that we have advised you to use. That is perfectly reasonable for the company to say, but the problem is the particular viral medium that you want to use with that test may not be available. Again, sourcing. Right now, everything is in short supply, and you're forced to use a different viral medium. Now it changes the sensitivity and specificity of the test. So it is very difficult to give a broad stroke answer for that. So you have to know within your own lab, what is the what test is being used, what viral medium is being used, are they being transported appropriately? Is there a different, in the transport chain? And that's why, as Dr. Petroza mentioned earlier, the tests are not being done in the clinics. And even mine, even though I said that our decision is to test every patient going for egg retrieval, the tests are being done in a specialized center within the institution. So all the patients have to go to this particular area, which is a drive-through, again, to minimize contact. Literally, patients drive and they open their, the window, and the staff walk up and actually do the tests on them. So it is really the level of detail that goes into planning this is incredible. But those are the things that unfortunately you have to work within the local context to understand and implement. With respect to the second thing about the sweating, and I can only imagine, having lived in India for the first part of my life, the only answer is core temperature monitoring, right? But then that defeats again. Now you're going to introduce another element of infectivity there. I honestly don't know the answer to that. Yes, people sweat so much and they walk in and they may be now suddenly in an air-conditioned environment within the clinic, and there's wild variations in temperature fluctuations on the surface of the skin. It's an excellent question, but I actually don't know the answer to that.
Just to add Bhagavat to your comments, one of the things we're seeing with our test here in Massachusetts, and like Bala said, there's at least 5, and here in Massachusetts, because there's Harvard and MIT and the Broad Institute, they all have little tests they're working on as well that our hospital's been experimenting on. But one of the things they mentioned at a recent conference I listened to was that the validity of these viral RNA testings is really also based on the level of virus that you have. So it's a lot more sensitive when a person is newly infected and the viral levels are high in that patient. As the patient becomes with less viral load, the sensitivity of the test actually goes down. And so there's so many factors that go into the testing and into the positive and negative predictive values. And all you can do is try to find the one that gives you, that's the most validated and the most predictive.
So just anecdotal that we in India are struggling so much with the RT-PCR for tuberculosis. It is a major controversy in the gynae forums for a long time. And now we had the COVID added to it. That's all that I can say. We are going to struggle with this test as well, because RT-PCR itself is very sensitive. The technique is such, and there are so many variables and so many confounders. So it's bound to happen.
In the dire emergency operation, probably we have to take the all prophylaxis. That has to be done because you have to save the life. That is the only answer, I believe.
That's true.
Yeah, there are again. Sorry.
I would just chime in and just say I use a tennis analogy, and the tennis analogy is when in doubt, it's out. And so kind of applying it to this, when in doubt, they're positive. And just always go with that. And then you just need to have a protocol to strategize what you're going to do. Just know if you have any suspicion at all, what are you going to do with that patient, whether it's a retrieval or whether it's an elective surgical procedure as opposed to an emergent surgical procedure.
Treat everybody as positive and go ahead with your precautions.
Maybe the multi-specialty hospitals may have more patients of inflow and outflow. This may be another difficult task. And standalone clinics may have little more preventive, one can have the more precautionary place. So it may be possible that interlinked inter-infections probably may be less in this case. This is, I feel.
Well, there were a couple of questions again, which were related to whether that, is the virus going to affect the oocytes, embryos. I think Dr. Sonia has really taken it well, going to tell that there are no ACE2 receptors. But I think a lot of, people, the audience want to know, in the way when we start, how are we going to have any method where we could protect the lab or the infrastructure and our personnel? And I think, again, we would like to hear, because we will be drawing these and we'll be putting this in the guideline. But I thought, since these are very relevant questions from people who are wanting to know, would there be any methods where we could protect our own staff, particularly in the embryology lab, during the OR places, and also what about the working units where we are working? How do we ensure that there's going to be COVID-free?
Well, I would make a few small suggestions. It would be, one is to rotate staff, minimize the number of people that are in the lab, although you always have to have 2 to verify who you're inseminating with. But again, a rotational system and trying to keep as much distance as possible, just like you would do in the nursing staff and with patients as well. But that's the first one that pops into my mind. My
thought is, most laboratories are positive pressure rooms. I'm assuming it's the same in India. Yeah. Your embryology staff are probably more in tune with universal precautions than anybody else that you experience. The only risk I can see is when you're collecting, your follicular fluid. Theoretically, you could get aerosol attaching to the tubes and whatnot. Just make sure they're disposing of their gloves, wiping and sanitizing the surfaces, the same precautions that you're using for any other room where there might be exposure. I think the lab is going to be okay.
Yeah, I echo John's thoughts. I think the people in the whole ART clinic situation, the people who are most protected are the laboratory people. They're going to be the most protected. The people I have the greatest sympathy for are the phlebotomists, your nurses or ancillary staff who are actually bending down and trying to draw blood from the vein of these patients. Their head's going to be as close to their face, you know. Think about it. They are the most actually at risk because they cannot stand at arm's length and draw blood like that. They have to bend down and they are going to be getting their heads closer to the patient's head. So those are the things that we've been thinking about, asking the patient to keep their face, even though they're wearing a mask, turn their face away from them, you know, maximizing as much as possible. Even the front office staff, we can hang a plexiglass screen in front now that we didn't have before to, again, maximize the shielding. Really is the phlebotomists, in my opinion, who have the greatest risk of exposure to this. The laboratory staff I have the least worry about. It's theoretical. We know now this virus spreads through respiratory system. And if our lab people are getting exposed, then our technique is so terrible. You know, you can't even imagine that happening.
I would say, you know, there's a couple of my embryologists who are very anxious and very concerned, and they said, could I get fitted for an N95? I said, I don't think you need an N95, but if you want to wear an N95, please go get fitted for an N95. I can guarantee you in a hot lab where you're keeping the temperature controlled, they'll wear that N95 for about 20 minutes and then take it off and switch over to a regular mask, because it is not fun wearing an N95 mask for long periods of time.
Yeah.
I would also like to add one other thing in our practice. As we gauge the sensitivity of all the staff members, that includes laboratory as well, there's various degrees of concern. Concern is not a right word, but heightened anxiety. And we have been very liberal in those that have a heightened anxiety is to not have them work. And that is just the policy or the way in which we've decided to deal with it, as opposed to forcing people to come in and make it mandatory that they work. So we're trying to gradually do this and show that that everybody can be comfortable, but we have not forced everybody to come back in and work. We want them to do it on their own accord. So just again, another thought to think about.
I think, thank you very much. Dr. Sonia, would you like to add something to what we've heard from our other speakers about the lab or anything on the...
I think that should be making the comments, I think. Thank you so much for this opportunity given to me.
And before concluding, we have few more questions. A lot of questions are there. We'll just shortlist few more, but looks very important. This question is to Dr. Bhagwat. You have mentioned about COVID testing on the day of HCG. Should we do testing on the day of stimulation, starting stimulation?
So that's the question that we all struggle with as well. Patients pay a lot of money for this out of pocket, and it's not ideal to cancel on the day of trigger, on the day of retrieval. But then if you test them on the day of stimulation, that makes sense. However, if they're negative, that doesn't still preclude you from testing again on the day, because the real danger is on the day of egg retrieval, right? So we still have to test them again. So that means, again, your capacity to test, right? Do you have the capacity to test each patient twice? So testing resources are also low. So that's the minimum. Of course, if you have the capability to test twice, and the patient now has to pay for the testing too, right? So it's all adding cost to the whole thing. So it's a good question. In the ideal situation, if we had the ability to test, we would test on the day of stimulation, make sure that they are not infected. But then by the time they come for egg retrieval, on average 10 to 12 days, right? From the day of stim to the day of retrieval. And now they could be infected again. So you have to test them again. So there is no going around or avoiding the testing on the day of trigger or the day before the egg retrieval, but whether you can or should is left up to local resources for the day of stim.
And if they happen to be positive 2 days prior to the trigger, should we cancel the cycle or should we proceed with?
Yes, and that's what I said in my presentation. The decision is that we will cancel, and the patients are advised ahead of time that that possibility is there. So if they are not willing to take that possibility, then unfortunately we can't proceed. It's a very, very important part because, again, it is informing the patient ahead of time. If you as I said, the only caveat was those at risk for severe OHSS, because again, now you're balancing the risk, and if the patient has to or likely will end up in the hospital, now you're further exposing the patient who is infected to a lot more people while she is in potentially serious condition as well. So for that reason, I think Steve and John, you can correct me. I think ASRM itself, I don't know whether it was spelled out clearly in that for severe OHSS, you can go ahead and do the retrieval, but in other cases, we cancel the case. We cancel the whole retrieval.
If you're doing your test before the trigger, and you're getting your result before the trigger, so we made a protocol for my center. We haven't started this yet, but I've put down the protocols, and I have actually listed 2 testings, but of course it depends on what is the cost and what is going to happen. I have just listed it. But if you have not given the trigger, then the risk of OHSS doesn't remain that much. So in that case, you can just cancel the cycle by giving whatever you wish to, in order that she doesn't go into OHSS. Rather than making her go through it, there is a possibility that despite the pickup, she may. And then she's in a bigger soup because she's in OHSS and she's a COVID positive. With both those and with this risk of thromboembolism now, you're in a bigger soup. So I think it's better to cancel the cycle.
But in India,
yes. Sorry?
But in India, all asymptomatic patients, all patients need not to be tested. This is what is the guideline says. Not all patients should be tested. So we take the consent, we take the initial form, we screen them properly, and we ask them, these all possibilities are there. If it is going to be, say, maybe you have a symptom in between and you comes out to be positive, probably we need to cancel the cycle. And all that consent form and everything is being told to the patient, and then only we are going to start. We are going to start now after this lockdown, and we have been streamlining the protocols in our center here. No.
And once when we start.
Can I just add to what she said, Bharti? The only thing is, yes, you're saying that the guidelines are saying that asymptomatic patients should not be done. But then having said that, it probably will have to differ from specialty to specialty. We as a specialty would be a little different from the others, I think, because the sensitivity of our problem is different. We may be passing on to the next generation, as we are saying in the conversation, when we are freezing the embryos, when we are doing various procedures. And I actually think that point that Dr. Petroza made, that it could be coming from the intestine when there may be a soiling while you're cleaning and it goes into the vagina. You may pick it up in the follicular fluid, and that may be the cause for all that is happening. So I think even asymptomatic patients must be tested in our specialty, because the question is on to the next generation, which is, I think, a big problem which we may face. So I think we shouldn't.
But looking at Dr. Sonia, looking at the specificity and sensitivity of this test.
Yeah, we will soon get the ELISAs as well. So we have the rapid testing as well as the PCR, both together. We may be a little better off. So it's just a question of time where we will be able to map out the entire testing for our patients. I think
from IFS the guidelines like this to test all asymptomatic patients as well. Yes. The one who enters into the lab from IFS task force, is it going to come like this?
I don't know, that Dr. Sudha has to decide.
We are going to make the task force, and then we will come on conclusion what all patient has to be tested. But I feel personally the asymptomatic patients are more challenging. Yes. We do not know exactly what will happen patient, patient is asymptomatic. Once you do stimulation and do the oocyte retrieval, probably this patient can turn up, and the post-operative period, even for the mother, for the patient, will be very, very difficult to take care. Talking about the oocyte and the
now
this may be the
test has
probability.
no, testing is also itself is a challenging. Testing itself is a challenging. All the centers, if they start testing, is very going to be difficult. It has to be specific testing to specific places. And those specific places, again, will be a very big challenge in India, because there are very few places where this testing is going to happen, because we have done to our patients. It is very difficult for them to go there. So for asymptomatic patients, I'm still, I don't know really whether we should be going for each and every patient at the time of oocyte pickup, at the time of stimulation. How it is going to happen, I don't really know.
Just one thought, since we are concerned about asymptomatic patients, could we sort of have that asymptomatic have it at the start and somewhere by the, say, day 7 or 8 of stimulation, and then one more just to be a double proof, because we may have a false negative, and then to, face a surprise on the day of the pickup, you could probably have another, testing coming somewhere between day 8 or day 10. To be very sure that we're cancelling. I know we're going to increase the cost, but look at the cost that's involved in taking the cycle further rather than halting her and cancelling her earlier. So I think if we make guidelines, we could put this, and this could not be sort of, compulsive, but especially if you're an asymptomatic patient, it definitely calls, because for a symptomatic, we all are prepared. So my thought was, I would just like to hear Dr. Bhagwat and others. Do you think it could make sense? Maybe logistics are there, but then could sort of add to, not the cost, but safety.
Safety.
I can see the argument both ways. I think it has to be a combination of feasibility, number one, as we have talked about. Do they have to travel kilometers and kilometers to a special center to test? How feasible it is to get the testing done? What's the cost involved in that? All that is going to determine. Of course, an ideal scenario, if we can keep testing, and if it is 100% sensitive, in addition to having a very low chance of false positivity. Because the other thing you have to think about is, if the test is false positive, then you're going to what's the rate of false positivity in these patients, and you're going to cancel them for no reason. So many factors need to be considered before coming to a conclusion. As a national guideline, I can see you guys struggling with it as a national guideline. I think that you have to look at the broad possibility and look at what guideline would suffice and help the most number of members in your society, and also societal factors in that. Because if the guideline is so stringent that you are going to exclude most of your members from adhering to the guidelines, that's not going to be helpful as well, right? So it is a very sensitive and balancing act to perform at this point. And the big problem is that we have very little information. We are arguing about, is it really important that the virus could be found in the follicular fluid, and what does it mean, right? We don't even know what it means. But the more important part here is the risk to the staff in the ovum pickup unit, right? The anesthesiologist, the nurse who is there, and the doctor. What are we? That is really the critical part that we are worried about most here, rather than anything else. I think that is the main problem to address. Are we putting ourselves at risk from a patient who could potentially be infected? And that's the reason why we are planning to test on the day of trigger or the day after HCG. And the reason for the plan to cancel is the result, even though I said it's now the turnaround time is 2 to 4 hours, they're prioritizing the results, okay? So in a day, as the patients are driving through these stations, getting their tests done, what they're doing is they're tiering that, tier 1, the ones that are right now going for an emergency C-section or an ectopic, those are now the stat testing. And then the OPU is not going to be the stat test, unfortunately, when they tier that. So you are not, even though the capability to get the result in 2 to 4 hours is there, we are not going to get it until the next day. And that's the reason for saying we are going to do that and then we'll cancel because it'll be too late. The HCG trigger would have already been administered that night and the results come back the next day. Unfortunately, it's too late. But you're right, as Dr. Malik said, if you can do it ahead of time before you even give the HCG and have the result back, that would be ideal because then you don't even give the HCG. So it's a complex question. I think you have a big task ahead of you to figure that out in the Indian context.
And it is very common with regard to IUI patients. Should we do testing on the day of IUI? The husband and wife, should we do testing? Because that's the one procedure which we are going to start right away, isn't it?
Right, but there is no risk of aerosolization here as opposed to egg retrieval. And that's why for IUI, there's no recommendation to test. And as Dr. Petroza said, we've already had patient who the husband wanted to be at the delivery, was clearly symptomatic, did not inform. The patient also did not inform. And so he was there at the delivery and immediately as the baby was being delivered, he collapsed. And then the whole thing came out that everybody, and it was such a big, exposure to so many people. So we can't, unfortunately, trust, even though we love our patients, we want to trust our patients, we have to be cognizant of the fact they may not answer truthfully to the questionnaire. So the questionnaire is not also very helpful. So taking all the precautions, every patient to wear a mask coming in, we are saying that no partners allowed for the same reason, we can't trust, and we just want to minimize risk to not only to our staff, our clinic, also to other patients who are coming into the clinic. So we don't want to be the clinic that is on the headlines as to being an epicenter for another outbreak.
The biggest problem is such patients, Dr. Kunjubudin, who are asked to come for procedures that do not require much of anesthesia, no anesthesia, and say, for example, even a semen testing. So, they will definitely object, saying, why are you testing me? Why should I go through a COVID test? But that is mainly because you want to protect your own staff and yourself, rather than you're not, like he says, they may not be telling us the truth. So therefore, if we are better prepared after doing a test, it may be better for us. But that is the reason now all the centers are advising that the semen collection should be at home and you should be bringing that container with you, even for pickups. So having said that, so we are telling our patients to go away from our clinics, even for small things like semen analysis, where it may, or an IUI preparation for that matter. So therefore, we have to think about that and maybe institute it as a protocol even for smaller procedures, just for the safety of our own clinic and also for the safety of the other patients who are more sensitive to this whole problem. There are so many women who do not want to come to the hospital just because they are scared they'll get it in the hospital. So many families, they don't want to come. So we have to respect their feelings as well. And maybe for that reason, we may have to put this as a test, as essential. But again, as Dr. Bharti says, it may not be possible because everybody doesn't look at it the same way.
Very right.
Yeah.
I think one of the nice things that hopefully when this settles down is that, as you said, Dr. Malik, we're going to sort of re-look at our structure and how we do our processes within our clinic. For example, at Mass General Hospital, just like you said with sperm analysis, we actually had a curbside semen analysis drop-off. We would send men kits in the mail. They would collect at home. They would drive by to the entrance of our unit. We would go in, grab the bag, check the ID, and that worked well. And we started to say, we're going to do this now for all of our semen preparations. We worked with a company that was able to do certain blood tests at home, just with a finger stick, where they could do day 3 FSH, estradiol, AMH, TSH, prolactin. And we're going to incorporate that now as part of our practice, where patients don't necessarily have to come in. They could do a finger stick at home. Telemedicine is going to be, I think, the norm. Our practice, the way we see our patients, is perfect for telemedicine. We don't have to do exams on all of our patients. A lot of what we do is based on verbal communication. And I think one of the things that we learned very well, at least in the Boston area, was when we were starting to shut down, we were finishing our last patient before one of my sister institutions, academic centers, was finishing. And we worked out a relationship so that our cancer patients would continue at our sister institution because they were still moving forward with the last bit of their fresh cycles. And I think trying to consolidate and trying to maximize the utilization of your PPEs, we have to put aside our differences as independent centers and try to work together to sort of say, how can I strategize to maximize PPEs, yet still take care of the patients? And I think those are the certain things that are the silver linings in all of this.
Consolidation.
Yeah,
working together.
I have started in our practice, almost 95% are traveling phlebotomists that go to all the patients' homes or will meet the patients. And it's amazing how our medical care more than likely is going to completely transform as a result of all of this. So, you know, most of the andrologists, embryologists were so reluctant to doing offsite semen production. And now it will probably become standard of care, just as like you're saying, John.
So with this session,
things which we have been learning from this pandemic, I think these are all challenges. It's wonderfully done. Yeah. Go ahead.
Yeah.
Concluding, I would like to express my sincere thanks to Dr. Bhagwat because just by Wednesday only we have finalized on the program, and within 48 hours he could organize all these speakers. And special thanks to Dr. John, Dr. Steve, and I hand out the mic to Dr. Sudha and Dr. Nina for the concluding remarks.
Just one thing, Kunju, could I sort of announce at this meeting, this webinar is going to give people ICOG points. We have talked to the Indian College of Obs and Gynae. So those who have logged in can get their certificates and they get credit points for attending this meeting. So thank you very much. Thanks, everyone. Thanks, Kunju. Thanks for having us in for this wonderful webinar.
Thank you so much, Dr. Bhagwat. Thank you so much, Dr. Petreza, Dr. Stephen, for giving us so much informative messages. And I hopeful that these messages will go to the audience also, and they will really work out. But we are watchful. What will happen at the next moment, we do not know. So let's see how the things goes during this pandemic. Thank you so much once again.
Thank you very much. Thank you very much.
Thank you all.
Thanks for having us. Have a great evening.
Thank you.
Thanks.
Congratulations.
We have stopped shaking hands. It's a thank you now. Namaste.
Yeah, just wave out now.
Yes.
Just wave.
Yeah.
Specific Dr. Steve, special thanks. Dr. Sonia ma'am, special thanks. Thank you.
Thank you so much.
See you again.
Definitely, yes. So it went very well. I really congratulate Dr. Kunju. You have done, at a short interval, you have done the best thing. Thank you.
Thank you. And also we had almost 1,000+ attendance.
Ah,
well done.
Well, very well done. Very well done. At the last moment, one point also came from ICOG.
Yeah.
That's good. Okay. Thank you very much. Thank you so much.